Welcome to episode 9 of the GLP-1 Hub podcast. I'm your host, Anna Reisdorf, registered dietitian, GLP-1 user. Today we have a super interesting topic. Dr. Andrew Shapiro is here to talk about using GLP-1 after a breast cancer diagnosis. This is actually a common complaint that I've heard from a few friends that have had breast cancer. If you are looking for more support on your GLP-1 journey, make sure you're in our Facebook group. You just want to search GLP-1 Hub support and community on Facebook and check out some of the new resources that we created on the website glp-1hub.com. There are some ideas for healthy high protein lunches, healthy high protein dinners. So you are going to want to get that, and lots of exciting things coming down the pipeline at GLP-1 Hub that I am really excited to share with you. But let's get to the episode. Welcome to the GLP-1 Hub podcast, and I am so excited to welcome our guest today, Dr. Andrew Shapiro. He is the head of Advanced Surgical Physicians in Wellington, Florida, and also the medical director of the Comprehensive Breast Center at the Wellington Regional Medical Center. So thank you so much for being here, Dr. Shapiro. Can you tell us a little bit more about your practice as a physician, a surgeon?
Sure. So board certified general surgeon, practicing the full spectrum of general surgical care, two-physician practice here in Wellington, Florida, and cover everything from minimally invasive surgery, hernias, gallbladders, different types of cancer, breast cancer, colon cancer, cutaneous oncology, so things like skin cancers, melanoma, and also doing medical supervised weight loss.
Okay. So how are you combining your surgical expertise and practice in surgery with the GLP-1s? Like, how do those things intersect?
Sure. So at first, it certainly could raise an eyebrow and say, hey, well, explain to me, how a surgeon's doing kind of medically supervised weight loss. And it really took us a little while before we even wrapped our own minds around offering it to our patients. And I think the thought process was kind of multifactorial. So one, I don't have to tell you, obviously the obesity epidemic and the population in general, certainly has been struggling with weight for a long, long time. And we see that just in our regular medical general surgical practice, right? We have patients who have hernias and complications from hernias because of their obesity or their excess weight, people not recovering from surgery as well, complications like wound infections because of their size and their weight. And then making operations when they do have to have them even more challenging because we have to contend with whether it's visceral fat, and adipose tissue on the inside or subcutaneous tissue that we have to get through to take care of them surgically. It just, lends to less healthy populations. So from a surgical standpoint and what we do on a daily basis, we thought, well, if we could help folks get to healthier weights, that would make their recovery better. And this isn't necessarily something that's going to impact them in the short term when they need an acute operation or even an elective operation in the short term. But from a long-term perspective, how do we help people get to a healthier weight? Is there something that we can do to make future patients, potentially have better outcomes or less complications or tolerate surgery better? Mm-hmm. And then when it really came to the cancer patients, every time we do a cancer follow-up, one of the common questions you always ask is there any unexpected weight loss or any weight loss? And, if I had $1 for every time a patient said to me, oh, I wish, kind of set off a little light bulb to say, well, is there something we could do to help these patients navigate their weight and get to a healthier weight as well? So that's kind of how we got to the point where we started offering this medically supervised weight loss program within our own practice, not only for our cancer patients, but all patients in general.
So a couple of questions, because I know there are certain surgeries that people need to have, hip, knee, things where it's beneficial for them to lose weight before the surgery. Sometimes that's indicated. I've worked with patients who had to do that to get those surgeries. So are you using the weight loss like to prepare them for some of those surgeries, or is it mostly after right now?
Yeah, it's mostly after. I think and this is a debate that goes on in the surgical literature for years, especially as it relates to hernia surgery. Should we be offering or operating on folks who are obese or overweight when we know that there's increased risks and potential complications associated? Mm-hmm. And there's two mindsets. There's some surgeons who say, well, I won't operate on these folks if they're not at a healthy weight because I know it's increased the risk of complications or increases the risk of recurrence or things like that. I was always of the mindset that's not really doing the patients a service. Weight loss is not an easy thing. It's easy to say you need to lose weight, and it's a whole other thing to be able to do it. And so if it was easy, very few people would be overweight if it was as easy as just telling people they needed to lose weight. So I was never of the mindset where, or very rarely of the mindset where I required people to get to a particular weight before I would proceed with surgery. Mm-hmm. As I said, very few occasions. But so really more a mindset of looking at as overweight or obesity as kind of a more global situation, mm-hmm. and how we can help people, not necessarily related to an acute surgical episode or surgical care, but just more globally and in general.
Okay. So you maybe recommend it after, if it's a surgery they really need. You're not going to be like, you need to lose weight for 6 months and then I'll operate on you.
Correct. Not for most of the things that we're seeing. Correct.
Okay. And so I want to talk a little bit about the breast cancer side. My mother passed away from breast cancer, so it's something that's near to my heart. And so in terms of GLP-1s with breast cancer, because I also have a friend here in the neighborhood, and she's been complaining about weight gain after breast cancer treatment. So can you explain to me what happens there with the weight gain and why women experience that after the breast cancer?
Sure. I'm sorry to hear about your mom.
Thank you.
And your neighbor. So, a couple of things and how we kind of got to working with breast cancer patients as well. My wife actually works as our cancer navigator here in the office and works very closely with all of our cancer patients, especially our breast cancer patients. And, as a personal story for her, she has several autoimmune conditions. And as a result of one of them, ended up needing to be on high-dose steroids for many months, probably about 6 months. And as a result, with high-dose steroids, as most people know, one of the side effects of those is weight gain. And so she probably gained about 50 pounds or so just from being on those high-dose steroids on a daily basis, and was able to get off the steroids, thankfully, and everything resolved that she was being treated for, but struggled with getting those 50 pounds back, getting those 50 pounds off. And so spoke with her doctors, right? Spoke with her rheumatologist and her primary care provider, and all of them why not try it? She expressed interest in starting GLP-1 medications, and they saw no reason for her not to do it. And so she started it and was able to lose, 50 plus pounds. And not only did she see the weight come off, but she started getting improvements in some of her inflammatory issues and her joint pains and just a general sense of overall wellness and improvement. And it kind of clicked with her to say, so many of these breast cancer patients that we're seeing not only struggle with weight, but have some other symptoms or side effects from medications that, we recommend for them for improving, their long-term survival and decreasing the risk of recurrence. And, the thought kind of popped in her head at that point for these patients as well, say, why not see if we can offer to them and how they could improve. To answer the question about the breast cancer patients with as we said, so many folks start out being overweight already. Then we take care of them for their breast cancer. We put them on these medications to try to prevent them from getting or lower the risk of getting a recurrent cancer or a second cancer, which have side effects of weight gain and, aromatase-induced arthralgias and joint pains and things like that, mood swings and liability and all that kind of stuff. And we address one problem and potentially create other issues. And so with her experience, seeing how it helped her feel better and all these aches and pains and the weight loss, we thought, why not, see if it could help our breast cancer patients as well. In terms of breast cancer, GLP-1 is a peptide, which technically is present in our bodies already. But are there any contraindications if you have a history of breast cancer, if you're on any of these medications, anything somebody should be aware of? Yeah, no, thankfully, no. Related to breast cancer. And so one of the things that we certainly do with our breast cancer patients when we discuss GLP-1 medication initiating therapy is we discuss it with their oncologist to make sure they're on board and make sure they don't have any concerns regarding the treatment that they're receiving from their standpoint, whether it's, an aromatase inhibitor, a tamoxifen, some other type of medication. We typically don't initiate therapy if they're receiving active chemotherapy, whether that's neoadjuvant or adjuvant chemotherapy. Mm-hmm. But once their treatment's been completed, they're done with surgery, they're done with their, chemotherapeutic regimen, and they're on their anti-estrogen type medication. We'll discuss it. The patients are interested. We'll discuss with the oncologists. And we're actually having the oncologists refer their patients, even if they're not are breast cancer patients, other surgeons' patients, or other patients that they're being seen in the oncology practices, they're actually referring to us now to help facilitate and manage their medically supervised weight loss because they're seeing the benefits from it. But as far as absolute contraindications, really only a few. So folks who have been diagnosed with medullary thyroid cancer or multiple endocrine neoplasia type 2, those are absolute contraindications currently. There's some relative contraindications. We discuss folks who have had pancreatitis as something that needs to be looked at further or considered about whether they'd benefit from GLP-1 medications. We know these medications do have an increased risk of inducing or causing pancreatitis. So it's not, as I mentioned, an absolute contraindication. If a patient's had an episode of pancreatitis in the past, it doesn't mean they're absolutely excluded from GLP-1 medication, but it definitely warrants a more in-depth conversation to determine what the cause was, if there could be something identified that if somebody had gallstones and they developed gallstone pancreatitis, probably in and of itself not a contraindication. But if they've got some type of inherent pancreatic issue that developed or caused the pancreatitis, that may be another story. We talk with some folks who, the GLP-1 medications delay transit time, gastrointestinal transit time. So folks who've had a previous diagnosis or known gastroparesis or delayed gastric emptying, another relative conversation, but not an absolute contraindication because the medication's slow emptying. If they already have slow emptying, it might be something that, they may want to reconsider. But again, the only absolute contraindications are medullary thyroid cancer and multiple endocrine neoplasia type 2.
So how is breast cancer so much different from these other thyroid cancers? Because from my understanding, and you probably know more about the research with the thyroid cancer, that cancer was seen maybe in rats on the research. Yeah. So how, it can cause one type of cancer, but not affect the breast cancer or increase the risk of recurrence? Do you have any thoughts around that?
So I wasn't going to bring up the rats on your podcast, but you did. So I guess we'll go there.
Hey, sorry.
So the GLP-1 receptor agonists stimulate the C cells, which are different cells in thyroid tissue that are not present in breast tissue. And, as you mentioned, the research kind of suggests a relationship. I think the current feeling is that it doesn't cause thyroid cancer, but if someone's already at risk for having had an issue with these specific types of thyroid cancers, medullary thyroid cancer, which is related to the C cells, then maybe we don't want to stimulate C cell hyperplasia or overgrowth and make more of them or increase the risk of there being a reaction or a development of that type of cancer. But the C cells are not related with the breast at all. And so that's why, all cancer not created equally and not the same. It all depends on the different types of cells. But that's the difference between the breast and the specific type of thyroid cancer. And just as a point, there's multiple types of thyroid cancer. So the most common type of thyroid cancer is papillary thyroid cancer. There's a follicular type of thyroid cancer. No contraindication to using GLP-1 medications in patients with history of papillary or follicular thyroid cancer. It's just specifically the medullary type.
So in terms of I know GLP-1 has some anti-inflammatory effects. Do you think that long-term those might help lower the risk of certain kinds of cancer? Because cancer related to inflammation, can you speak to any of that?
It's hard to, I don't know that it would necessarily lower those other types of cancer. I think from a management standpoint, from a symptomatology benefit standpoint, certainly we're going to see it, patients doing better and feeling better and navigating their other diagnoses better. But I'm not sure that we're at a point right now where we could say that these GLP-1 receptor agonists are going to help lower, other types or lower any types of cancer. I don't know that we can say that now. Yeah.
Right. Because there's just so many factors that go into cancer in general, right? So it's just hard to say. So when somebody has had a diagnosis of breast cancer, how are you treating them? What's your protocol? Do you, try to use the prescription GLP-1 or using compound? What is the protocol in your clinic?
Sure. So, for us, really, it's however the patient can get access to their medication. The challenge has been access. The challenge has been really twofold. One, it's access to the brand name medications. Either the pharmacies are not in stock and it's not accessible that way. And the second challenge is obviously the coverage, right? So lots of folks' insurance, unfortunately, isn't covering it for obesity, even when it's indicated and appropriate. And so really our practice is such that if the patient can get it prescription, either through their insurance or not through their insurance, great. If not, then we have done compounding. And I think one of the advantages of the compounding medications is the ability to really tailor the dose. As you know, the brand labeled medications are set doses, and that's how they were, approved. And so they start for the tirzepatide, it's 2.5 to 5 to 7.5 to 10, et cetera. And not everybody needs to necessarily be on 5 if they are not having desired out benefits at 2.5. And so, one of the benefits and advantages of the compounding is the ability to really personalize and tailor the dose to the needs of the patient. If someone can do well on 3 milligrams, why do they need to be on 5, right? If 2.5 is not working, but 3 does, why do we need to give them extra medication that's not beneficial for them? And so that's one of the advantages. The other advantage of the compounding is when we use compounding, we add some other medications. So we'll add B12, which will help to combat some of the side effects of nausea that some of the patients will experience. Obviously, B12 also gives them a little bit of boost of energy. We also add glycine, which is an amino acid, which we feel is beneficial for trying to avoid and decrease some of the muscle loss that can be associated with weight loss.
Interesting. So are you concerned at all about access to the compound with all the recent changes?
Yeah,
Every day is something new every day.
Very much so. No, I think it's going to be a challenge to the patients, unfortunately. We saw this even before, or even with or what was reported as a shortage or lack of access. We were having patients, we've had patients who have come in with our program and it was being covered by their insurance, then it was not covered by their insurance. They were getting it at a pharmacy, then the pharmacy no longer had it in stock and they weren't able to access it. And what that lends to is just patients not being able to be consistent with their medication. They're not able to take it on a regular basis that they need to maintain their health and their progress and compliance. And so it's definitely a challenge, and obviously more to come and levels above our influence, I guess. Definitely just see where that goes as far as the compounding pharmacies and their ability to continue to provide.
Sure. I think there's a lot of new things on the horizon. I saw that some of the prescription, like Eli Lilly was offering a ship to the patient option for a little bit less, but I don't know. It's just so expensive. So what about getting off the medication? That's something that a lot of people are curious about. I'm a GLP-1 user. I tried to get off the medication and it did not work for me.
Right.
So now this is my friend forever.
Right. And can I ask, are you at the same dose you were on when you were actively losing, or have you gone down to a lower?
I decided I wanted to lose a little bit more, so I went to 5. I tried 7.5 once, and I couldn't eat anything, and I'm a food person, and that was miserable for me. Like, I literally had one tiny bite, and so that wasn't going to work. So
Sure.
I'd rather lose like 2 pounds a month than not be able to go out to dinner with my husband. Like, that's just not an option.
It's a great point, and it's a question that comes up often. And honestly, when it doesn't come up, I make sure it comes up and I bring it up, because I think it's one of those things where I like to look at it with the patient from a perspective of it doesn't have to be a lifelong medication, right? So it can be. For many, it probably will be. I think it has the potential to be demoralizing or a defeatist attitude if you say you're going to be on this forever. Just have to accept it, right? So there are some people who I think will be able to use the medication along with all the other things that we discuss and implement in the supervised plan that we offer, counseling and nutritional support and exercise. Right? It's not a program of restriction or exclusion. But it's a tool to help people get to a healthier weight. And some people will probably be able to get to that healthier weight with the medication and come off it and change their lifestyle in the process and change their eating habits in the process and change their psychological mindset in the process to where they can come off of it and not regain a significant amount of weight. We know that many people will regain. Their studies show that most people will regain some weight, not all of the weight, but some will regain some weight. And whether that's enough to be satisfied and stay off the medicine, is individual preference. But I think the mindset, like you, and the perspective that you shared, as far as so many folks are viewing this as like anything else, a medication that might need to be long-term or lifetime. And then it's a matter of managing that and individualizing and tailoring the dose. So whether that's a maintenance dose, if somebody's on 5 and they're able to maintain their success at 2.5 or even lower, or instead of doing a weekly injection, doing it every 10-day or 2-week injection. It really is, I think that's the beauty of the medication, is it is able to be individualized and tailored to not only the goals, but also the long-term success.
Sure, sure. So you mentioned when you were with that answer that you guys are offering exercise counseling, nutrition counseling, and that kind of stuff. So are you working with other allied providers for that, or is it all within your group?
So we do have some colleagues that will refer folks out too. We also provide the basic information here as part of the introduction to kind of the thought process and mindset and comprehensive plan. Many people don't require an athletic trainer or some type of physical trainer or a dietitian or nutritionist. I think, the information that we can provide usually is encompassing enough to get folks started on where they need to go. And then, for many, it becomes kind of an addictive mindset of, I like the results I'm seeing. I want to learn more. I want to do more. And then they kind of take it from there themselves. But we, advocate some light strength training. All right. This is not something that, again, I think one of the nice things about the program is the medicine really does help people kind of get kickstarted into that weight loss. Even if they don't change their dietary habits, the fact that it causes the early satiety, it controls the cravings, it quiets the food noise that many people struggle with. And as a result, it decreases the caloric intake and the counseling comes into play, where making sure people are mindful that since they're going to be eating less, they need to make sure they're eating quality foods. So proteins and fruits and vegetables first, as opposed to carbohydrates and empty calories, and making sure they're maintaining their hydration and staying hydrated so that they don't have issues with dehydration. The light strength training, we've got plenty of people who don't exercise at all and they're still losing weight. But obviously to maintain muscle tone and muscle mass, a little bit of light strength training, 10 minutes 3 times a week. Doesn't have to be a ton. People think they have to do all or none, or they have to exercise for 200 minutes a week. Really, there's been studies that show that just 10 minutes three times a week are beneficial enough, and it doesn't have to be anything more than body weight, right? You don't need to go out and buy dumbbells and fitness trainers or gym memberships. You can do it sitting in your chair at your desk, just moving your arms and using body weight resistance.
Yeah, and I think that the most important thing is the consistency. So if it's 10 minutes that you can do, and you can do it all the time, rather than trying to do the 200 and then end up doing 0, I think that's better. So I want to ask you, what do you think the future is for these GLP-1s, peptides? Do you see anything for cancer treatment, or do you see anything that's interesting to you as a surgeon and as working with this population?
No, for sure. I think across the spectrum of healthcare, we're hearing and seeing so many beneficial reports coming out across disciplines. So, so our gastroenterology colleagues are seeing significant improvement in fatty liver disease or non-alcoholic steatohepatosis, right? So they're seeing fatty liver improvements from the GLP-1 medications. ENT colleagues or otolaryngologists are seeing improvement in sleep apnea, which at first you take a step back and go, well, of course sleep apnea is getting better. They're losing weight. Of course, they're not going to have as much issues with sleep apnea. But I actually had a patient I saw yesterday who's lost about 25 pounds, sleep apnea better, not having sleep disturbances, still 25 pounds, but had to come off of his medication, his GLP-1, for surgery. And noticed that in the 3 weeks he's been off it in preparation for his surgery, his sleep apnea has gotten worse, even though his weight hasn't increased, right? So he's still the same weight he was before, noticed an improvement in sleep apnea, had to come off the medicine to get ready for general anesthesia, and noticed that he was having sleep disturbances from his sleep apnea again. And so I think across the spectrum, the rheumatologists are seeing improvement, as I mentioned, with some of these autoimmune conditions and inflammation. I think as the research continues to be performed in the different disciplines, we're going to see it looks like we're going to see so many benefits that these medications can offer.
Right. And have you looked at any of the research on some of the new medications? There was an article that came out a few weeks ago in, I think, Nature or something, that talked about a bunch of new ones that work even better.
Right. Right. Well, if you think about just the tirzepatide, right, the dual agonist compared to the original semaglutide, it seems like as we learn more and more, there'll be more and more opportunities to investigate them and see how they can help our patients.
Right. Right. No, it's exciting. Do you usually recommend tirzepatide over
We
semaglutide
do.
or yeah?
We do. We do. In our experience, so we did, as I mentioned, we were very strategic and thoughtful in our integration of the program.
Hmm.
So did a lot of research about the different offerings and the different medications available. It just seemed that most people shared that there were less side effects or fewer side effects associated with the tirzepatide compared to the semaglutide, as well as it seemed to have a better weight loss profile and a more sustainable profile. So we've not ever prescribed or utilized the semaglutide. It's just been the tirzepatide, and we've had, our patients have had phenomenal results. Not everybody responds. There are certainly some who struggle. It's hard to know if they're struggling because they're not completely compliant with the recommendations. Hydration is paramount. We've got a lot of folks who don't stay hydrated. They like their carbonated beverages and their sweet teas and things like that.
Hmm.
It seems that those who stay hydrated, those who focus on their protein consumption really do very, very well. And those folks tell us, when they fall off, they're not staying hydrated, they're not taking as much protein, they're not being mindful. They do see that they, either gain or relapse or don't lose as much as they had when they're, diligent about, and it's not about counting calories, it's not about measuring macros and all that kind of stuff, but people know when they're eating protein or they're eating junk. People know when they're, staying hydrated or not. And so those kind of things help with the success for sure.
Sure. Sometimes you got to be accountable to yourself, not just blame the medication. Because you'd be like, oh, this doesn't work for me. But like, what are you really doing? So do you work with patients just in Florida, or are you able to see patients virtually? Can you tell me just a little bit about that?
Sure. So we're just working with folks in Florida right now.
Hmm.
A lot of this, since it's medical care, even though we're able to do things remotely in telemedicine, my license is in Florida, so I can take care of patients remotely throughout the entire state, but not outside the state currently.
Okay. Cool. Cool. Well, thank you so much, Dr. Shapiro, for being here. This has been such a nice conversation. And I'll be sure to put any links to your clinic if people are in Florida and they want to work with you and learn more about what you're doing over there.
Appreciate your time. Thank you for having
Thank
me.
you.
Thank you so much for listening to this week's episode of the GLP-1 Hub podcast. Make sure that you connect with us across all of the social medias. We are on Instagram as GLP-1 Hub. We have a Facebook group, GLP-1 Hub Support and Community, and then also on YouTube if you are not watching this there, GLP-1 Hub. And then we have a website with lots of resources for you as well. If you want to connect more with our guest, make sure to check the show notes and please consider leaving a review. And wherever you're listening to this podcast, it helps our podcast grow, get more guests and keep it going. Written reviews are always welcome. So any feedback that you have, I'm happy to hear it. And I'll see you next week.